Hey guys, welcome back. Bruce and I are back here talking about a different topic, and we're gonna flip it a little bit. Where instead of Bruce asking me questions, I think I'm gonna quiz Bruce a little bit, since this is one of his areas of expertise. But the short of it is today we're diving into one of the most confusing areas in clinical practice: concussion, dizziness, and vestibular symptoms. Bruce and I have created the content for an upcoming course, the Advanced Specialty Practice course, which we're super excited about. And we're teaching the first round of these courses later this year. As a bit of a teaser, I wanted to kind of flip things, as I mentioned a little bit with Bruce, where instead of him kind of interviewing me and asking me questions, I'm actually going to interview Bruce tonight. Because honestly, Bruce, he treats a whole bunch of concussion and vestibular cases, and to be honest, he's pretty freaking good at it. These cases where clinicians often feel like progress is unpredictable, patients improve, then they regress, and it can be a bit difficult to know what system is actually driving the symptoms. So, what I really want to do is get into kind of unpacking the physiology behind some of these cases and talk about how to reason through them a bit more clearly. Sound reasonable, Bruce?
Sounds good. Let's do it.
Well, let's start with the fact that many clinicians say concussion and dizziness patients are some of the most frustrating cases that they see. Symptoms fluctuate constantly. So, my question is, why do these cases feel so unpredictable?
I think they feel unpredictable because clinicians are expecting a singular diagnosis. We're expecting a single system problem when we're actually dealing with several systems that are interacting together.
Okay, but what systems are we talking about specifically?
I mean, there's a lot, but I think the biggest players involved are the vestibular system, the visual system, cervical proprioception, cervical spine, and autonomic system. These systems feed information into integration centers in the brainstem. You and I talk about this all the time, especially the vestibular nuclei. The nuclei combine signals that come from the inner ear, the eyes, the cervical spine, and determine where the head and body is in space.
Right, so basically you're saying that it's a mismatch of signals. That is often what is causing dizziness for patients.
Right. If one of those systems becomes unreliable after injury, the brain starts receiving conflictive sensory information. The vestibular system may signal movement, the eyes may signal something different, the neck may send distorted positional based information. The brain now has a bunch of different signals from a bunch of different systems, and the data is mismatched. And that mismatch is often corresponding with the symptom of dizziness or nausea or some form of disorientation.
Okay, but why do patients sometimes feel fine during therapy, but then they report feeling worse later?
Um, each of these systems has their own threshold. It has their own tolerance. So a patient may tolerate controlled exercises, but they become really symptomatic and kind of get that nasty feeling after prolonged time at their computer or looking at the TV too long or they're reading too long because of visual fatigue in that instance. Or another patient may feel like walking makes them dizzy in a grocery store. That's the
There
good
it
old
is.
grocery store.
Why the grocery store? Like, why is this always the classic example?
there's it's a multiple combination of sensory loads. So I mean, you've got visual motion, scanning, lighting changes, head movements. There's a large demand on balance depending on the patient type. So what looks unpredictable is often just different systems reaching their thresholds in different environments. We need to, as clinicians, we need to start asking which system exceeded its tolerance today, especially during treatment, and especially those times where you're coloring outside the lines. If we start asking that question, then these cases begin to become a lot easier.
Okay, so let me ask you this. Like another challenge clinicians typically face, and I'd say this definitely includes me too, is determining which system is actually driving the symptoms of dizziness. Like patients often just say that they feel dizzy. How do you differentiate whether the driver of the dizziness is cervical or vestibular or visual or even autonomic?
First thing we have to think about is that dizziness is not a diagnosis. And we often get our referrals from patients dizzy. It's not a diagnosis, it's a symptom description. And I think that patients use the word dizziness to describe a couple different scenarios. It could be spinning or feeling imbalanced, or they feel like they're floating, or they feel lightheaded, or maybe they feel disoriented. Each of those symptom descriptors could be coming from a totally different system. And so I think the first step is we need to clarify what experience that they're having.
So what questions do you usually ask?
Um, there's questions I ask, but I will say, I think a lot of vestibular therapists kind of feel this way. We try not to lead with questions because if I lead with questions and ask them, "Oh, do you feel vertigo?" That's the classic, right? That may feed them information that they want to answer yes to. I want to ask open-ended questions so they can tell me what their experience is. If we're, the classic, if we listen and we're quiet just long enough, our patients genuinely will tell us what's wrong with them. So if they're really having a hard time, I always say the hardest thing I ever ask patients to do is describe what their symptoms are. And if they're really having a hard time, I may ask questions like, does the room spin? Or does reading or being on your computer trigger it? Or does head movement make it worse? Or does standing make it worse? And hopefully you get answers to some of these questions and they start revealing some patterns.
So what would suggest a cervical driver to you?
So if, in your subjective, and of course, your subjective exam is what gives you the information in regards to how you're going to do your objective examination, right? If I don't have time to do 50 objective measures during exam, we're all running out of time clocks here. So if dizziness occurs with neck pain, they have limited range of motion, they have a sustained posture for a prolonged period of time, like I'm starting to think cervical, and I'm going to start running some tests based upon that. If the upper cervical spine contains a dense concentration of proprioceptors. You and I talk about this all the time. It's most, what is it? The most grams per concentration in the entire body is in the suboccipital muscles. And if these signals become distorted due to injury or muscle guarding, the brain receives inaccurate information, disorientation. So that mismatch can produce. If I hear those kind of answers, I'm thinking cervical.
Getting back to, your ability to identify which patients fall into which categories when it comes to dizziness, like to you, what are some vestibular drivers?
So, I mean, I'm thinking people with motion sensitivity. People struggle with head turns. People struggle with more busy visual environments or balance during movement. Um, the vestibular system stabilizes through that VOR reflex and then contributes to postural control. So if that system's impaired, motion tolerance decreases. People are really off balanced in particular, not even necessarily they're dizzy, they're just off balanced all the time. I'm really thinking vestibular.
That's reasonable. And I mean, I guess to come full circle, how about like just visual drivers? Because obviously the visual system plays a huge role in imbalance.
I think more processing. I think more, someone who's reading or someone who's, like I'll bring like a little checkerboard pattern up, or I'm like wearing, I wear plaid shirts every Friday in the clinic. They're like, oh, I can't handle that. I'm like, now we're thinking visual as a driver here. So convergence, saccades, smooth pursuits, working on accommodation, all require coordinated neural activity between it. So if we're starting to see symptoms like that, now I'm starting to think visual drivers. But it also may push eye strain and headaches and fatigue. um, I think that's a common thing I see a lot is that people misinterpret brain fog as visual fatigue and processing fatigue. So I think that's a symptom cluster, and you and I talk about clusters in ASP quite a bit.
Yeah, I
Um,
mean, that's
symptom
particularly
cluster.
interesting, especially in a post-COVID world, where you got a lot of, long COVID sort of stuff and brain fog, or and somehow everything gets blamed on COVID. But
You would
here's a
know,
zinger.
we had an hour-long discussion earlier this week on post-viral infection neuro symptoms. So we can
Yeah.
really go full circle here.
Let me give you this zinger. I mean, how then does the autonomic system fit into all of this?
So I mean, often that autonomic dysregulation appears with exertion. So, it's those patients who are, like for example, they may feel nausea. We see that a lot with POTS and with autonomic dysfunctions, but and we think, oh, nausea is BPPV. Not necessarily. Maybe the autonomic nervous system is really what's involved here, and they're getting fatigue. They feel like they crash after activity. Their heart rate spikes significantly. And I put someone on a treadmill, and all of a sudden their heart rate's up at 160. After walking 1.52 miles an hour, like I'm starting to think autonomic. So the key point, though, is that the systems that we're talking about is that they overlap, and we have to identify what the dominant driver is and what the system is involved in this patient's experience rather than focusing on a singular diagnosis. And there could be secondary and tertiary systems that you're working on, but a lot of the times there's a primary driver. We're figuring out what that is. We're working toward those issues, and then we can clean up the rest of it with the rest of rehab of what you're working with.
Yeah, and I can imagine, I mean, your ability to treat the patient is only going to be as good as your ability to figure out like what category that the patient fits into, meaning the driver of the problem, right? Like if you're not able to figure that out, then you really don't know if the treatment that you're providing is actually geared towards the right patient. But I'll tell you another frustrating thing for me is recovery timelines. So, patients often improve, like I said before, and then suddenly it seems that symptoms seem to flare up again, right? For a clinician, like that's the ultimate nightmare. And like, why is recovery from concussion or in patients that have had, that have post-concussion so non-linear? Like, why is it so variable?
It's non-linear because we're not just healing tissue. Like obviously, like with a concussion, for instance, like, you have that coup or that counter coup injury where tissue itself actually has to regenerate. But the brain is also recalibrating the systems of where the damage actually took place.
What systems do you think are being recalibrated?
So, I mean, everything we just talked about, the vestibular input, the visual processing, cervical proprioception, autonomic regulation, all these things have to reintegrate and have to adapt. And each system, depending on where the injury took place, what tissue is trying to recover, and the individual's experience, they're all going to recover at different speeds.
So symptom flare-ups don't necessarily mean that something is wrong. I mean, really what you're saying there is that you're just activating different systems en route to the, right, as part of the recalibration process, in which case it's kind of to be expected.
Yes, and I feel like that can be a frustrating thing too, and especially for patients, they may feel like, oh, I took a step backwards, or like that appointment we did less and actually it was harder. But just often that means that the patient encountered a sensory load that exceeded the tolerance of that individual system. So for example, visual systems, they fatigue really quickly. A patient may tolerate, 5-10 minutes of reading, but they develop a headache after 30 minutes. And so that doesn't mean that reading is harmful or a bad thing for them to do. It means the endurance is still building. And in some cases, if they're able to do it for longer without having symptoms, then I wouldn't say it's a setback. I'd actually say it's progress.
Does the autonomic system influence this too?
Yeah, I mean, and that's when we start talking about some lifestyle stuff with these cases, not just from a concussion or a vestib or with any of our patients, sleep, hydration, stress, anxiety, exertion, physical exertion, all influence autonomic regulation. So those factors can shift symptom thresholds on even a day-to-day basis. So instead of asking, are symptoms gone or how are you feeling, we need to start asking, can you tolerate this activity, this particular activity more? Or do symptoms resolve faster? Or are flare ups less intense of some of the symptoms you're experiencing? Just like with everything, but in particular with these complex neuro cases we're talking about, progress is never linear. It's wavy, but hopefully it's waving. I should do it this way because the camera, right? But it's waving upwards. We may have some dips depending on especially dosage. We talk about dosage a ton, but we want to see trending upward waves.
So you know that one of my favorite topics to talk about is rehab technology. And certainly when it comes to this patient population, there is all kinds of interest in what technology can be used in patients that have had a concussion or they've got, vestibular problems going on. Where does technology realistically fit, though, in the treatment of this population?
I've got all sorts of toys and tools and fun things to use with this population. I've got random cards with numbers on them and colors on them and shapes on them and patterns on them. And I show videos on a screen that I broadcast on the TV, and I use Frenzel goggles. It has its place. It can be useful, but we do have to understand its role correctly. These tools don't fix these cases. They simply help dose vestibular rehab or concussion-based care more precisely.
So can you give me an example?
So yeah, visual tools. They allow us to adjust speed and complexity of tasks accordingly. So visual tools allow controlled head movement and gaze stabilization. We can use technology kind of on both ends of the spectrum here. So an example, like I'm talking about the visual tools, like I'll throw a video on that has, weird patterns or weird colors, and they're having to track something with their eyes while keeping their head in a turned position, or I may have them on an uneven surface, whatever levers or knobs I'm trying to pull in regards to dosage. But technology can be useful on both ends of the spectrum. We can allow for graded exposure so systems adapt without being overwhelmed, and a lot of the time on the other end of the spectrum it allows us to increase the dosage to the point where normal life is not able to force adaptation to occur. So, especially in vestib rehab, we talk about a compensated and a non-compensated vestibular system. And when someone's uncompensated, that's when they're, really unbalanced and really falling over, or they're staggering through your clinic trying to hold on to stuff. Um, I think that a lot of the times we have to, I draw this bar graph to these patients all the time in the office. It's still patent pending, but we can't train at the normal life level of what that regular human being experiences and expect what they're at to adapt to that. We have to train up here. That is what's going to cause neurological adaptation to occur. And a lot of the times, the stuff that we do on a regular basis just isn't enough to force that adaptation. So if I have some technology that can train us above the normal level of activities of daily living, then I'm more likely to get progress a lot faster. So let me flip it to you because you talk about
All right.
technology quite a bit, and one of the things you talk about in OBH, for instance, is GVS, the galvanic stimulation. So talk to me about that. How do you see, go full ray on it, do it. Talk to me about the physiology. Talk to me about how it works. Talk to me about um, how do you see galvanic stimulation fitting in cases like this?
I think one of the biggest misconceptions of galvanic vestibular stimulation, which is really just an offshoot or an application of transcranial direct current stimulation, is diagnostic. Like it's not diagnostic. We're not using it to determine whether a patient has vestibular dysfunction. Rather, we use it as a way to dose vestibular input more precisely.
Okay. Explain, because I can talk about increasing dosage with VRT and VOR training, and most of us understand autonomic grading and progressive, loading and training. But GVS, what is it, and why would I use it, Ray? Give me the meat and potatoes on it.
Well, remember, galvanic vestibular stimulation, as I said before, is really just a different way of using transcranial direct current stimulation. And transcranial direct current stimulation is a way that we can use an anode and a cathode to produce an electric current. and we can use that electric current not necessarily to make the neurons inside the cortex fire because it's not strong enough to do that, but we can use it in order to change the resting membrane potential of those neurons. So we know that most neurons of the cortex, they live at minus 70 millivolts. And in order to get those neurons to fire, we have to depolarize the membrane, which means that as we depolarize it, we make the inside environment of cells more positive, or we make it so that it's less negative. We bring it from minus 70 millivolts to minus 60 to minus 50 to minus 40 to the point where we reach a threshold, which is an all or nothing response, at which point now the neuron actually fires. It typically releases glutamate, assuming we're talking about the cortical neurons, and that glutamate then is used to talk to the next neuron. Now, again, like transcranial direct current stimulation, it doesn't have the ability to actually reach an action potential and get neurons to fire. But what it does do is it changes that resting membrane potential so that instead of neurons living at minus 70 millivolts at rest, they live just at the threshold. So if the threshold is minus 40, for example, it makes it so that they live at like minus 45. And now in those patients, it's going to take significantly less stimuli in order to actually push those neurons over the edge and get them to fire, right? What's cool about transcranial direct current stimulation is that we know that if it's not strong enough to actually cause an action potential, then we're likely not getting the glutamate that's required for early long-term potentiation. Rather, what we get is something called brain-derived neurotrophic factor. Brain-derived neurotrophic factor is interesting because after it's released by neurons, it's recognized by TrkB receptors on other neurons in the area. And when TrkB receptors receive BDNF, it kind of provides a backdoor to what's known as late long-term potentiation. It's almost the same cascade of events, which is required to get CAMP and eventually CREB and eventually CRE, transcribing the parts of the genes that are necessary to produce new dendrites, new axons, release new neurotransmitters, add more receptors for those neurotransmitters. And in doing so, it makes it now so that neurons are able to respond to each other in a way that's more efficient, right? This is essentially how we get to plasticity in the brain and how we change the cortex in a way where we can learn new motor tasks, we can learn new skills, we can create new memories, et cetera, et cetera. But if you apply the same principle to the vestibular apparatus, yes, the vestibular apparatus is technically not in the brain proper, but we know that the vestibular apparatus is made up of a series of neurons that have different jobs, right? We have the neurons of the utricle, the saccule, the semicircular canals, and those neurons are responsible for providing information about position and about motion to the brain so that the brain can interpret that information and then use it to provide appropriate corrective strategies so that the patient is able to improve their balance and not fall, right? This is particularly advantageous if you think about older people. I mean, older people in the main have a lot of problems because they they're so unbalanced and they end up falling and then they break a hip or they hurt their knee or whatever it is. Well, why is it that a lot of these older people, have this balance issue? It's because in large part or in many cases they have a hypofunctioning vestibular apparatus. The neurons which live in the utricle and the saccule and the semicircular canals are not firing in a way which is timely, in a way that's appropriate, right? And when that happens, it means that information about how the patient is moving in space or how they feel with, respect to that space isn't being transmitted to the brain fast enough so that the brain can provide efficient strategies in order to get the patient's body to move in a way to stop them from that imbalance or to stop them from falling, right? So one thing that we can do then is use this galvanic vestibular stimulation, not necessarily to make the neurons of the vestibular apparatus fire, but to change their resting membrane potential to make it so that they're right at threshold. And in doing so, make it so that those neurons are now more sensitive. So now in those patients, it's going to take less stimuli. It's going to take less activity, less time to actually get those neurons to fire to deliver appropriate information to the central nervous system. And now that the central nervous system is getting that information quicker, it can then provide whatever the strategy needs to be, right, in a way that's more efficient so that the body can actually move in a way that creates strategies or balance strategies so that the patient now is going to act in a more appropriate way so that they don't fall, right? So essentially, we're making it so that the different parts of the vestibular apparatus are now going to be significantly more sensitive, or another way of saying it in older people is they're now going to fire in a way that's more appropriate given imbalance. If we can do that by using this technology, we can now make it possible so that these patients' brains, their central nervous system, will work in a much better way to keep them from falling in the first place, right?
So, so this is again just like this is something that is being used for controlling exposure, not diagnostics.
Yeah, we're using this as a treatment strategy. We're using this so that the neurons that are responsible for telling our brain where our body is in space or how we're moving in a way which is longitudinal acceleration or vertical acceleration or whatever it is really now acting in a way which is more sensitive to provide the brain in a more efficient way, in a quicker way, with the information that it needs to tell the body how to move to keep the patient from falling, right? It's essentially taking a hypo-functioning system and making it now so that the neurons are living like right at the threshold that it would take to create an action potential. It essentially, that's a fancy way of saying that now these neurons are going to be more sensitive and that these patients are now going to have more timely strategies in order to keep from falling in the first place.
And
We
I would
can also
argue,
use the very same technology instead of just beefing up the vestibular apparatus and making it more sensitive. We can also kind of use it to trick the vestibular apparatus, right? Like we could put the anode on one side and the cathode on the other. And in doing so, we can stimulate one vestibular apparatus and inhibit the other. And in doing so, make the patient feel like they're falling left or right in one direction more than what they usually would, so that it will force them to make a corrective strategy in the opposite direction. So, as you might imagine, like this sort of a thing would be key for more neurologically impaired patients, like maybe a patient who has had a stroke, maybe a patient who has now Pusher's syndrome, to actually prompt their central nervous system directly via the vestibular apparatus to push in the opposite way of what they think they should.
I think what I like about it the most is that, like you said, it creates a more hypersensitive vestibular system. And like the analogy I made earlier of like, they're here, here's human life, and we have to train them here. Now we're rather than doing, I'm using technology and I'm making them turn their head on an uneven surface while looking at a weird pattern while the ball is moving. Well, I can just use galvanic stimulation to already put things at a pretty high level of sensitivity. And then I can do something really simple while doing that rather than having to try to reinvent the wheel and I'm pulling 20 levers at the same time.
That's right. It is essentially going to make the neurons fire given much less stimulation. The stimulation that you're trying to provide with all of your different balance treatments, whether it's turning the head, walking on a balance beam, Whatever that is, it is going to make it more likely that the neurons of the vestibular apparatus will fire in a more timely way to more efficiently deliver that information to the parts of the brain that matter so that the brain can create the appropriate strategies to improve that patient's balance.
I love it. I mean, I do think that technology has its place diagnostically too in these cases. You've got like for concussions, you've got impact testing, which has a lot of evidence behind it and giving you a little bit more specificity. You have VNGs that are diagnostic materials, but I do think this is another great example of this is a way to grade exposure and dosage versus diagnostic. I really think that's where technology, for the most part, has its place in treating this patient variant.
For sure. For sure. Yeah. And I mean, and it's really something that you can use with any patient that has a vestibular apparatus problem. If it's hypofunctioning, you can use galvanic vestibular stimulation. Even if you have one side which is hyperfunctioning and the other side is hypofunctioning, you could even use it to balance that. So there's a whole bunch of different options. And the great thing about galvanic vestibular stimulation, much like transcranial direct current stimulation, is it's pretty cheap. I mean, we're talking about something that's $150, maybe $200 if you want to get a fancy one. But in the
And
world
you,
of
like we talked
balance,
about the other day, you could use TDCS machines on it, but at the end of the day, like a lot of the literature talks about milliamps being a little bit higher than a TDCS device is capable of doing, right?
I mean, that's true, but if you get a good TDCS machine, it will go up to the milliamps that you need to do vestibular stimulation, right? Like, I mean, at the end of the day, it's just really where you're putting the anode and the cathode. Are you putting it over the cortex on the outside of the scalp, or are you putting it over the mastoid processes? But you are right to say that the milliamps are a little bit higher than what you would use for the cortex, and the pads are a little bit smaller because now we want it to fit on the mastoid processes, right? Which obviously are smaller than the area of the cortex.
And there's the
So
point stimulators too, but then you can't really move or like do anything, versus like the pads. Have you
yeah,
seen those before? Yeah. Like
that's
once you
fair.
hold it up there, it's tough. So there's a lot of different options out there for people, but I think this is just the theme of what we're trying to get across. And we could talk about physiology all day, but I think the theme is like mostly used for dosage and not necessarily diagnostics.
Yeah, I mean, it depends on what you're talking about. I mean, we like to talk a lot about needling too, right? And when we talk about needling, now we're thinking about patients where there is a cervicogenic component to their dizziness. And the cool thing about needling is we can use it for both. Like we can use it both for diagnostics and we can use it for treatment, right?
For
Because
sure.
if you're putting that needle as, the study by Escaloni et al. Showed, and you can stick it in some of those suboccipital muscles, particularly the obliquus capitis superior and inferior, the rectus capitis posterior major and minor, the semispinalis capitis. I mean, if it's truly cervicogenic in nature and those muscles are part of the problem, it's going to make that dizziness worse. And certainly we're not trying to do that, but diagnostically though, it does make me happy because now I know that's part of the problem. And now I can wage war therapeutically, of course, at those muscles that are, a culprit of the problem. And I could really hone in on, some of those problem muscles in order to now provide a treatment, which is ultimately going to give me a better result.
For sure. I think that study in particular was obliquus capitis inferior, and just because it's right at C1, C2, kind of bridging that gap there.
I mean, you're definitely not wrong. But as another author that was on that paper, I I will tell you that it was definitely not just one muscle, although the obliquus capitis inferior was a big one.
You're on the paper?
Yeah. But there was a couple different suspects of the upper neck, which it's not always the same one, but the ones that I mentioned in the main are usually the big dogs.
Gotcha. Gosh, any other questions you have for me, Ray? I know we're kind of getting a little close on time here.
No, I mean, honestly, I think you provided a really nice summary. I mean, the big thing for me is figuring out how, figure out like which category these patients that have balance problems fit into, right? And then and then once we put them in the right bucket, then what are the things that, are the most evidence-based things that we really can do that really focuses in on those different buckets, right? And then what should the expectation be for those patients, as they're moving through their journey and getting better, right? And I think you made it very clear that there's going to be a lot of ups and downs and why that's the case. And I think the biggest take home for me is that patients, there's a lot of different systems that are involved when it comes to balance. And it's pretty rare that patients just fit into one bucket, right? There's usually more overlap, unfortunately, than not. And as a result, you may be going after one system, but maybe overdoing it on a different system, right? And that's why like you're doing the right thing, but maybe the patient ends up feeling a little bit worse before they get better. And that needs to be part of the patient education process. And then finally, I think it was really nice that you gave a shout out for technology. And while we certainly didn't talk about all of the different technologies that are available for this patient population, we will certainly talk about a lot more, especially the big dogs when it comes to the advanced specialty practice course.
Right.
Because I mean, I think, as in many of the courses that we teach in Torrentia, we really want to, arm clinicians the best way possible so that they really can provide multimodal treatment, which includes the very best technologies to improve their outcomes, to increase the value of what it is that we do, and to at least make clinicians dangerous when it comes to all of these different imbalanced patients so that, we can really up the game on what we do. So I intended that to be a summary, and I hope that it was. But
Nope, I agree. The big thing I wanted to drive home is that we need to treat systems and not symptoms, essentially.
yeah, fair
Yeah,
enough.
that I didn't want to talk about all the things that we're gonna talk about in ASP, but I know we talk about galvanic quite a bit in OBH. So, but no, I'm excited for that to come out and for us to do that I think this summer is our first ASP. So,
Yeah, it's one of those things where I get a little bit annoyed in the world of physical therapy by a lot of things, but in particular, like you go to continuing education courses and you come home, you expect to learn, one or two new skills for a certain patient type. And like, I really want our courses to be more about changing paradigm, and I don't want to go to like six different courses to be dangerous enough to be able to treat, a lot of these different specialty patient types, right? Like I really wanted us to have a course where, like people are going to go home and feel more comfortable treating post-concussion and vestibular problems, imbalance in general, headaches, temporomandibular dysfunction, even like pelvic floor, sexual dysfunction. I mean, I like to think that the advanced specialty practice course is going to be like the greatest hits of like three different courses all together in one thing.
but this is why it's 3 days.
Right.
It's intensive. There's a lot of information, but
Sure.
this is why it's a 3-dayer.
Sure, but I think the idea is we're going to really try to provide the greatest hits of what's evidence-based, to really give clinicians a good multimodal strategy for all those different things so that they could at least go home and be just dangerous enough to start to make a difference.
And if you're a clinic owner too, these are the patient variants that are helping you build a practice. Everyone's competing for ACLs, everyone's competing for orthopedics and post-ops, but um, the truth is, if you can handle one subtype variant of these patient type variants, you're going to be able to have a steady line of patients and referral sources just for this. And as you build a team and as you build different pipelines, like these are the types of cases that help you build a practice and build a reputation.
As you've heard me say a lot of times, the way that I think that we build our practice as physical therapists is not competing for the ACLs and the total hips and the total knees. Pretty much everybody says they can do it. It's the ability to treat the underserved populations,
The
the
person is
specialty
like, I've
pop.
seen five doctors, I've seen five of these providers, and no one can help me, but I heard that you could. Like, yeah,
Exactly.
let's do it. Yeah.
It's the patients that everyone else fears. I want to have the conversation about how to treat those patients. And I think certainly vestibular patients in general, you know, certainly post-concussion fits into that, right?
There's some
But
overlap for sure, but we're going to talk in ASP kind of the differences between those two things as
for
well as
sure, for
you know,
sure.
gaining.
So, Bruce, I appreciate your time tonight. Thank you for, succinctly kind of going through all of that with us. I think I hope that that was at least a solid tease for what's to come.
I think I'm going to take over. I think I'm going to take over next month, though. I have more things I want to ask you too. But thanks, Ray. I appreciate it. It's always great to talk with you.
All
Uh,
right.
well, until next time.